So the major thing in lumbar canal stenosis is that it is not a fixed entity. What do I mean by this? The changes that happen in the spinal cord, they are not just static changes, there are dynamic changes also. So what are these static and dynamic changes? So as in the first image you are seeing, whenever we do flexion, so with the forward bending on the flexion, the canal diameter would increase by 11%. However, with the extension or the axial loading, the canal diameter decreases by 9% and can go as high as a 67% reduction in the canal size. So this particular changes with respect to the position of the body is something that also add to the compression. Now, whenever you do axial loading or extension, when the canal diameter reduces further, that increases the epidural pressure. So once the epidural pressure increases, the blood supply, the blood that goes back, that is the venous blood supply that is going back, reduces. So there is a venous congestion that happens, and which eventually impacts the CSF circulation as well. So once the blood supply is reduced and there is a impact on the CSF circulation, there is a depletion of the nutrients. It alters the metabolism of the nerve roots, and then it produces the symptoms of the spinal stenosis or this particular claudication symptoms that come up. So as you're seeing, as you are bending the spine in the form of extension or bending behind, the canal being reduced in size, the nerve gets entrapped, and that is when they start developing the symptoms. In the first image, you're seeing that with the forward bending, as a patient is trying to bend forward, how beautifully the spinal cord is open and it is decompressed. And in the second image that you're seeing, the extension or the backward bending, that when it is happening, the spinal cord and the nerves are badly compressed. So this is a difference that you see with the forward and the backward bending. Now, Kirkcaldy-Willis cascade is a degenerative cascade that tells us why exactly and how exactly the degeneration happens that impacts the spine overall. So we consider a segment of the spine. A segment is two vertebral bodies and the disc space. So these two vertebral bodies and the disc space in between would form the segment. So these are considered to be a three joint complex. What is a three joint complex? So one of the joints is a disc, and the other posterior joints are basically the facetal areas. So whenever there is a circumferential tear in the disc and a radial tear in the disc, that will cause the herniation. And there it can be internal disruption also without things coming out, which causes the loss in the disc height. This loss in disc height can contribute to something that is the instability in the spine. Similarly, the posterior joints that are present, there is a lot of synovial reaction because these are synovial joints that happens. The cartilage gets disrupted. Followed by that is the osteophyte formation. The capsule laxity is there, which adds to the instability. So loss of the disc height and the capsular laxity contribute to the instability. Now these, as they contribute to the instability, the subluxation happens. Subluxation is the displacement of the bone one above the other, and there is a resorption of the disc space as well. So as the disc space is reduced, the bones come closer to each other. As they come closer to each other, this is a nerve that is coming out. Now, since the disc space was there naturally this inside, and as it is coming closer to each other, because of the disruption, this nerve got entrapped. Similarly, because of the instability, as the bones slide on each other because of subluxation, that causes the additive effect of the nerve entrapment. So the articular processes get enlarged in size, and also the laminae. Osteophytes form at the back of the vertebral bodies, which cause the central stenosis. So overall, the lamina and the osteophytes that form at the back of the vertebral bodies would be contributing to the central stenosis. Effect of recurrent strain at the level above and below the original lesion would cause the multi-level degenerative lesion and the multi-level spinal stenosis. So this overall is Kirkcaldy-Willis cascade, wherein a problem in one of the levels can cause a problem to be spread wide apart, causing the multi-level degenerative lesion as well. So remember that a segment complex would be a three-joint complex. One is a disc space, and the facetal joints is a pair. Hence, it is a three-joint complex. Two facet joints and one disc space would contribute to the three-joint complex. And overall, when both of these elements are degenerated, that contributes to the development of stenosis. Classification. Now, lumbar canal stenosis is a broad term. It has to be classified further. A lot of you are not aware of that there are classifications in place. So based on the etiology, it can be a congenital or an acquired condition. Congenital, in fact, over the time has been renamed to developmental stenosis. So what does happen? Naturally, the size of the canals in these particular patient is smaller as compared to the others. The prevalence of the developmental or congenital stenosis is 20% in the population. And these are the patients who develop more symptomatic with small amount of herniations and even with small amount of stenosis. They have a lot of symptoms as compared to what they should have had they had normal canal sizes in place. Anatomical classification, central, whenever there is a central stenosis over here, so that would be a central area. Lateral recess, so these are the area which are the recesses from where the nerve root is coming out. So this is a lateral recess stenosis. Along with that, when the nerve comes out further out in the foramen and the extraforaminal area, it might be foraminal or extraforaminal stenosis. So depending on the area where the stenosis is, it can be a central stenosis, lateral stenosis, foraminal or extraforaminal stenosis. Based on complexity, it can be a simple type of stenosis or a complex stenosis. So complex stenosis might have a cyst, it might have a subluxation, it might have really huge facets. So that increases the complexity. Based on the space available for the neural elements, absolute stenosis is when the space is less than 10 millimeters. Relative is when the space is more than 10 millimeters. But scientifically, if you ask in the routine practice, we don't follow this space available for the neural elements. We don't start seeing the report and see what is the distance. We don't generally follow this. We rather follow the clinical picture of the patient and what we see on the MRI rather than the millimeter measurement of the stenosis. Patient with congenital or developmental stenosis, as I discussed, becomes symptomatic earlier in life. Due to congenital narrowing of the canal in these patients, significant stenosis is present at multiple levels with little degenerative change. Patients with degenerative stenosis present later in life during their 60s have far more advanced degeneration in their spine. Females are more commonly affected with stenosis at 4-5 level, which is the most common segment that is involved. So remember, degenerative stenosis presents later in life during the 60s, and they have far advanced degenerative spine. Most common level that is affected is L4-5 level, and females are way more common impacted with stenosis as compared to males. Now, when we talk about the natural history of the patients who undergo the non-surgical management in lumbar canal stenosis, how exactly things happen overall on the follow-up when we are following the conservative line of management. So when we talk about walking, so there are three we are going to these patients with lumbar canal stenosis. One is a back pain, other is a leg pain, and the third is the distance of walking or the ability to walk. So whenever the first thing that we talk about the back pain, 10% worsen over time. 36% show improvement in the backache overall, and 54% of the patients don't have any change. They still are living with the same pain. Now, when we talk about the leg pain, 32% improve overall naturally over time, 13% worsen when it comes to the leg pain follow-up on with respect to the non-surgical management, and 55% of the patients remain unchanged. The ability or the capacity to walk, there is an improvement overall in the ability to walk of 29% of the population, 22 worsen over time, and 49% remain unchanged. Now, one important thing to see over here is the walking capacity is deteriorating in regards to the pain and the back pain, the leg pain and the back pain. So even if the pain is not increasing in intensity, the walking capacity is getting impacted. So this is the natural history of these patients, and hence whenever you take the history, you have to talk about all these three: the back pain, the leg pain, and walking. Why walking separately? Because walking is very much important, and that is the main thing that happens with patients in lumbar canal stenosis. And it may not just be the pain; it can also be numbness, which is restricting the walking. Hence, walking has to be dealt with separately.